Polycystic kidney disease. Now, this is not really going backtracking to module 1. I know we discussed AKI and CKD, but these are now some of the conditions that will lead to CKD. Polycystic kidney disease. This is a genetic disorder. So this is similar to other genetic hereditary conditions like Huntington's disease, for instance, sickle cell disease. So these are sad hereditary conditions. Your parents can pass it to you, and you in turn can pass it to your offspring, and the cycle goes on, right? So in just my personal opinion, since the condition runs in the family, maybe you should not have children. Okay? Maybe you should not have biologic children unless you can afford to, because you can do IVF, okay, in vitro fertilization. That's an option because you can, out of the several embryos that you have, you can choose which ones does not have the trait, and then you can choose that. That's an option. That's the only way you can have children with none of these disorders. Okay, if you can't afford it though, then maybe you don't want your children to have the same thing, don't you think? Yeah. Okay, unless I mean, that's just my opinion. Okay, I'm not saying that all persons with PKD should do the same, right? That's just my opinion. I mean, why would you, I mean, let's just use me for instance, okay? So why would I want my kids and my grandkids and then the offspring after that to suffer the same fate? Okay? Yeah. Okay, let's talk about this first. Okay, so what is it? Genetic disorder. So the problem with this is there's two forms. There's the recessive form and then there's the dominant form. The dominant form is the popular, most occurring form, meaning 9 out of 10 cases of PKD are dominant. So about 10% or less are recessive. When it's dominant, that means, here's the description. The patient has a high chance of developing it. The sad thing is you don't see it at birth. So unless you have a history, let's say you know your patient's history, plus let's say your parents did not manifest it. It was your grandparents who had it. So your parents simply had a trait and then now you manifest it. What happens is you grow up normal. By your 30th year, I mean 30th, no, third decade of life, then you develop the symptoms. Your kidneys develop these dozens, if not thousands or hundreds of fluid-filled cysts. Let's see if there's a picture here. None. So I'll show you a picture. This is what your kidneys will look like. So they'll develop these fluid-filled cysts, in which means when these cysts burst, then they're destroying your kidney little by little. Now, the cyst will overrun one or both kidneys. Usually both kidneys will be affected. And then there you go. No more kidney function. Okay, because they got destroyed. They will atrophy eventually. I mean, they're there, they're alive, they're not really dead, but they're not functional. So therefore, you resort to dialysis. Okay, so this is a form of chronic kidney disease. Okay, so early on, but that's not the end of your problem though. So the chronic kidney disease, which progresses to end-stage kidney disease, is toward the end. Until then, you'll have to suffer a few more things. Here, so here are now the cysts. The kidneys get so big, they become twice their size. So therefore, the kidneys become palpable. So since they're now so big, because your kidneys are normally the size of your fist, okay, or a little bit smaller. Now, since they get twice as big, so will they push abdominal organs out of the way? Can they cause bowel blockage? Can they cause pain? Yes, they are very palpable. So since it's big now, so now you can palpate the fluid-filled cyst, I mean the cyst-covered kidneys. And of course, that causes pain. Yes, you have a question? which part? No, specify the question.
Said that before you said end-stage kidney.
Right, so you'll have other problems. So here are the clinical manifestations. So as the kidneys become bigger, so you'll have the kidneys will be painful. They become palpable because now they're up to twice their normal size. So they'll cause, a bulging here, and it's painful when you palpate. And like I said, because you have other organs in the way, correct? So it will push the stomach, the small bowels, the large bowel. They can cause constipations, probably some bowel blockage if it's, depending on the position. And you'll have these symptoms. So there'll be blood in your urine, hypertension, because do you have chronic kidney disease now? Yes, and then there'll be some stones also. I mean, if you've heard of people who have kidney stones, are they comfortable? Okay, so one of the excruciating, painful experiences known to man. And there's UTIs and there's proteinuria as well. Okay, so these are the manifestations. And then the end result is you'll be on dialysis. So this is what I mean by you'll pass this on. Okay, because it's in your family. Okay, it's in your genes. So there's a chance your kids may not have them, but there's also a chance they will definitely have them. Yes.
So aside from dialysis, like, would that patient be basically in the hospital for constant issues related?
As the symptoms manifest, so yeah, let's say they get kidney stones, yeah, they'll be admitted. Okay. Pardon? That's all you can do. Yeah, that's all you can do. Unless you get, a transplant is an option. Okay. But again, the transplant list is quite long. We'll discuss kidney transplant next semester under immunity problems.
Yeah, that's what I was gonna ask, about a transplant. If you, like you said, sometimes we can test early. And what type of
Well,
test
we
you know
we
that you
can,
have?
let's say you disclose to your physician that it runs in your family. They can opt for genetic testing, but here's the key. What if you are positive? Then what? What are you gonna do? No, you don't need it yet.
Until it
Until it manifests.
Yeah, I mean, what are we gonna do? Dialyze you when you don't need it?
No, what I'm saying, can you do, if it's 100% there,
Huh?
and you have no signs and symptoms.
Again, that's the
can you do
question.
a
Okay, let's
transplant?
say you are positive. Then what?
You have to just wait it out until 30.
And then live your life, in constant fear. And so that's the downside of genetic testing. They'll give it to you. I'm not even sure if the insurance company will cover it. But let's say they do cover it. Then what? That's the next question. So yes, what if you are positive? What are you gonna do? The outcome is the same.
Would you
Yes.
start treatment earlier?
There is no treatment for this. I mean, what do
you
you
could
do?
wait.
It's in your gene. Yeah, you
You could
are
wait
gonna
until-
develop the cyst. Yeah.
Is your kidney?
Hmm?
If you're gonna have a new kidney too?
You can get a transplant, but again, it's not that easy to get. You have look at it. Who's okay, Sonjalin. Oh no, it's one not here. Okay, sorry, I'm thinking about another student. You wonder why so many people are on dialysis? If each one of them had the option to get a transplant,
Yeah.
nobody would be on dialysis. Okay, so you can just imagine, no, millions of people on dialysis. So what did that tell you about the chances of a transplant? Very slim.
But this
Okay.
will have 20 years to think about it. To save money for it.
Meaning you're a child, you think about it, because this develops in your 30s.
For your parents, to save money. For the transplant.
They need the money for their.
Again, it's if let's say you have millions in money, it's the match. What if you can't get a match? Okay.
Yeah.
Any other question? Yes.
Can they manipulate the gene or if they found that they're positive?
There's gene therapy, but that's millions of dollars. It's not like your insurance company covers that. No. So that's the option if you can afford IVF treatment, but that's of course for your offspring. Okay, so if you don't want, let's say you're lucky not to manifest it, but you have the gene, hey, you're afraid to, you want to cut it off, right? So you can do that. But then the embryo that you chose just means that that embryo doesn't have the disease, but then they still have the trait. So there's a chance that that child who may not manifest the disease will pass it on anyway. Okay. Again, it's just one of those things. We have so little control over, right? So again, PKD has no cure. So we just treat the symptoms symptomatically as they come. So if you have the UTIs, the kidney stones, then that will be treated. Okay, until the time that you do develop the disease full-blown cystic kidney disease, then you'll eventually go into CKD and then ESKD and then dialysis. That's about it. Any questions? Very short. UTIs. There are two different kinds. So we can have uncomplicated and we also have complicated UTIs. Then there's a third, which are catheter-associated urinary tract infections. But in any case, these are all caused by pathogens. So there's an organism, causative organism involved, and they cause the disorder. Our most so this is the second most common infection in the body, next to pneumonia. And for hospitalized patients or patients who are institutions, the most common cause is a catheter. So that's why the Joint Commission puts the core measures. Core measures, again, are standards of care. So if a patient, let's say, we'll talk about it when we get to the catheters, okay, under COTI, because it's a separate section. Now, if the patient meets those conditions that they need a catheter, then the Joint Commission core measure is 2 calendar days. Okay, so meaning that's the maximum you should have a catheter. Meaning if there's a reason, right? There's a reason why you got a catheter. So the doctor ordered it because there was an indication. So the most it should be in there is 48 hours. Okay, because after 48 hours, what's likely gonna happen? You will develop a catheter-associated urinary tract infection. So if we can help it, please take it out as soon as possible, meaning as soon as the indication is no longer present, okay, it should be removed. Of course, if you can justify, let's say the patient really needs it, then the doctor must order so. Okay, but the gold standard again is what? 48 hours.
Professor, if
Yes.
someone is in ICU and not conscious, what's like the longest that a catheter would be?
Again, that's usually if you're saying the patient is in ICU, that means they're critical, correct?
Right.
So that means the most likely indication for them having a catheter is to monitor hourly urine output. Okay, so let's say they're in shock, okay, they had a heart attack, okay, they're septic, for instance. So the reason why we put a catheter in those patients is to make sure we are treating them and that the only evidence of your perfusion, because we can measure central perfusion, but to measure distal organ perfusion, it's really only the urinary output. Meaning, if your kidneys are making 30 ml per hour of urine or 0.5 to 0.5 to 1 ml per kilogram per hour, then that means your organs are perfusing. Okay, because there's no other measure. It's usually measured by the urinary output, the hourly urinary output. So that would be the indication. So for that would be an exception, meaning the patient will get it as long as they need to.
And so like if someone was in a medical induced coma
Mhm.
and there.
Oh, for as long as, again, if they're hemodynamically unstable, but being in a coma is not a reason, it's not an indication for you to have a catheter, because we have other ways to keep you, to
So like
prevent.
They would use like a quantum
Right,
catheter.
because we have external catheters now. Okay, we have the brands are PrimaFit, we have PureWick, right? I don't know which ones your facility uses, but we have external
Yeah.
catheters now.
Okay.
If you're concerned about, skin breakdown because of incontinence, then we have those options now. Okay, it doesn't have to be indwelling, all right? But those PureWick systems though are not 100% reliable, meaning one small move by the patient, it leaks. So therefore they can't take the place of a
Measure.
catheter for measuring hourly urine output. Does that make sense?
Yes.
Okay. All right, so we have a sterile bladder. The bladder is sterile. However, the urinary tract, especially in the female, is not. Okay, so let's use the female. So because in males, there's nothing to talk about. There's one common reproductive and urinary tract. Okay, it's shared. However, in the female, it's separate. So you have the urethra above, vagina down next to it, and then the rectum. So all three orifices are separated by mere 1 to 2 centimeters. So therefore, the urinary tract is dirty, right? But we have a sterile bladder. So therefore, if you, let's say, miss hygiene, for instance, so of course the organisms will increase in number, and then they have the opportunity to swim up the urethra and then enter the sterile bladder, and then infection occurs.
That's when
Yes.
it's related to PKD, the fact that they're not alcohol, they can't clear the urethra, that's the reason why they're prone to UTIs.
In PKD,
Yeah.
well, you remember we have consequences such as the hematuria, and then there's calcium stones also. So those cause obstruction, and then they get the UTIs. Yeah, plus blood also, the presence of blood, because that's, blood contains sugar, right? So that increases the organism growth. Meaning if you feed the organism, then they'll multiply.
The fact that the urine output is low and there is any urine in it, concentrated.
Yeah. Mhm. Okay. So the technical term for UTIs is cystitis. So that's inflammation of the bladder, which is usually where the infection is, but you can call it urinary tract infection. Then there's also bacterial prostatitis if it involves the prostate gland in the male. And then urethritis usually is only present in sexually transmitted diseases, meaning a UTI does not cause urethritis. Okay, because urethritis is again a sexually transmitted infection, like from chlamydia or gonorrhea, syphilis, for instance. So those cause severe inflammation of the urethra, meaning it will burn, right? So I had two friends in college who were, they just frequent brothels, okay, and then they take turns having the UTI. Okay, so sometimes it's Johnny, sometimes it's Glenn, and to save money because they already know what antibiotics they need, so they'll just purchase it, because that's how it is in the third world. You have money, they'll sell you antibiotics. Okay, so they already know how to treat it, okay? So save money from the doctor. Anyway, so I've seen them, go to the bathroom, and then they dread going to the bathroom because they know how painful it is to urinate, because the urethra is very, very raw. Okay, it's very red, very, very painful, and they'll just go like this, just hold on for dear life, and then pee. And the rest of us are, of course, are just laughing in the background, enjoying their misery. So let's start with risk factors. So here are risk factors. Who are at risk for UTIs? So first is gender.
Female.
So females, diabetics, again, the urine has sugar, there's food for the organisms. Pregnancy, same thing. Neurologic disorders, because let's say stroke patients, spinal cord injury patients, brain injury patients. So what happens to their ability to urinate? Okay, so they're either incontinent or they have urinary retention. So either they can't pee or they are incontinent, gout, and then again, any other condition that causes urine to stay in the bladder. Like by neurologic disorders, we're referring to what we call a neurogenic bladder, meaning a bladder that doesn't contract anymore. Then there's decreased immunity.
How about causes?
Well, gout is a connective tissue disorder, and then because the urethra is a connective tissue, so it's affected, right? Invasive procedures, that's what we're referring to here, instrumentation, procedures that you inserted something up into the urethra. The problem again is, yes, we apply antiseptics. Okay, we clean the urethral meatus as much as we can, but do we really absolutely get rid of all the organisms? No, you can't. And then there's obstruction from these. Again, they lead to urinary retention. So if you have, let's say, congenital abnormalities, these are referring to fistulas, for instance, meaning is the vagina and the urethra connected? No, they're in separate tracks, right? But if you have a fistula, for instance, then they become connected. Or sometimes it could also be the vagina and the colon, for instance, the sigmoid. Sometimes they're connected, so feces comes out either through the vagina or sometimes in the urethra. Okay, so if you have those congenital anomalies, then of course you'll have UTIs, right? Because now your sterile urinary tract is contaminated with feces. They form usually in a cancerous process. Let's say you have any cancer or tumor growing in there, then you have those abnormal connections. And again, any condition that will lead to urinary retention, including kidney stones or bladder stones. All right, so I'll go straight to the manifestations. We don't need to know the technicalities. All right, so here are your signs and symptoms. So for females here, you should be familiar with these already. You know what a UTI feels like. So most frequent complaint is pain, lower abdominal pain, which is over the bladder. And there's burning on urination. Now, not as bad as the urethritis. Okay, so this is just simple burning, just like, have you ever had soap in your urinary meatus sometimes? Okay, it happens, right? It stings, right? So that kind of the same burning. Then there's frequency, urgency, nocturia, or blood also, but not all the time. So like I said, there are complicated and uncomplicated UTIs. And here is the manifestation. So if it's complicated, meaning these are serious organisms causing them. And if it's a complicated UTI, they usually progress to urosepsis. So this means that the infection went beyond the local urinary tract. It now entered the bloodstream.
So that's the complication.
Complicated UTIs. But there's other examples in the next paragraph. So I mentioned the neurogenic bladders, which increases the risk. So under the gerontologic considerations, so instead, on top of being female, then the elderly also are at high risk for UTIs. Male or female, same. And we have a special chart for the elderly. So these are risk factors that put the elderly person at even higher risk for UTIs. So most cases you see in the hospital are not the young people, but the older people in whether or not they have urinary catheters. Okay, so from nursing homes or from mental health facilities or even people from home, because these are again the disadvantages of being old. And all of us will eventually get old and we will have these as well. Okay, so for this section, now going back to the elderly, especially if the elderly patient has an indwelling urinary catheter. For those people, they usually have colonization already. What does colonization mean? Meaning your urinary tract is colonized with the organism.
They already exist.
Okay, they're there no matter what. Okay, no matter you treat it, they're always going to be there. Now, for those people who have colonized urinary tracts because of, let's say, a urinary catheter that's been there for months, years, for instance. Now, for them, we do not treat them unless they actually have symptoms of sepsis. Again, I repeat, for people with chronic Foley catheters, they usually are colonized already because, I mean, they have the catheter 24/7. So for them, we do not treat the UTI unless they show symptoms of urosepsis, all right? Because why? Why is that? Why don't doctors, do they not care?
Not bad.
Okay, because it's not really, because if we treat it, then we tend to create multi-drug resistant organisms. Okay, because they're going to be there no matter what. So now if you treat it, then you're just causing that problem, meaning the next time that they do have septic symptoms, then will the antibiotic work? No, the bacteria will laugh at it. Oh, this thing, you're fighting me with this thing? This thing, they'll just slap that bacteria, I mean that antibiotic around. Okay, so to prevent that from happening, we, again, for those people, all right, only get treated if they actually have symptoms. Okay, but other than that, meaning you get a urine sample, of course there's going to be bacteria there. It's guaranteed. This patient's having that, has had that Foley for years already, right? Yes, for people with chronic Foley catheters. But if the catheter is new, of course we treat it, because they're not colonized. Okay, so only in those chronic Foley scenarios. Yeah, permanently. I mean, yeah, they've had it for, more than just a few days. Okay, meaning they've had it for months or even years. Or some of these people have had them for decades. I mean, not the same catheter. Of course, we switch them every so often, because otherwise these latex catheters, what will happen to them? Yeah, they'll start, crumbling. Of course, we switch them, every now and then. So here are your symptoms again. Early, and then antibiotics are prescribed, of course, if there are bacteria present. Now, you may notice that you go to your doctor, you prescribe an antibiotic right away, correct? Right? Yeah. Now, they didn't necessarily do a culture, did they? They didn't do a culture and then wait for the sensitivity, right? They just asked for a simple urinalysis, right? And then it showed bacteria. We don't know what bacteria it is, but you have the symptoms. They just give you antibiotics. Now, there are standard antibiotics we use for common UTIs. So the UTIs that you guys have are what we call uncomplicated UTIs, meaning it's just because you're female, okay? Then you're young, sometimes you miss hygiene every now and then you get the UTI, okay? So, or let's say you have, you're a lot more stress than usual, lowered immunity, then you got the UTI. So they give you empiric antibiotics, okay? Meaning they know, the doctor 9 times out of 10 is correct that, oh, this is a common UTI. It's probably E. coli. Okay, and most of the time they're correct. Okay, it's just from fecal matter that went into your urethral meatus. Okay, so they prescribe traditional antibiotics. We'll get to that on the next page. So we do cultures only in complicated UTIs. Okay. Because we need to, especially if this patient came from a nursing home or has been hospitalized for a while, then we have to identify the organism to effectively treat the organism. Okay, and then we have the doctors will follow this criteria. So if you belong in these, then you should have urine cultures drawn. Okay, so all children UTIs, because kids should not have UTIs, because they're not sexually active. Okay, these are young children, so it doesn't make sense. Why would a young child have a UTI? Okay, so it's not typical. All men, because men are typically not prone to UTI, right? So we should have cultures drawn for men. And I already mentioned, institutionalized patients, or let's say they had an invasive procedure, or are diabetic, or they've had multiple, meaning, why are you having frequent UTIs? Okay, so that's suspicious, right? And the others are self-explanatory. Let's go straight to management. Okay, so if it's bacteria, which most cases are caused by bacteria, then we give you antibiotics. We don't get me wrong, when we said we're gonna do cultures for these patients here on this list up here, doesn't mean we wait, because it takes 48 hours to grow anything on the culture. Okay, so meaning those 48 hours, are we just gonna leave you untreated? No, we're gonna put you on a broad spectrum antibiotic first, and then change it if necessary. If, let's say, the culture turns out that the organism is not sensitive to what we're using, that's the only time we change it. But most of the time we catch it. Okay, it's quite rare to say, oops, wrong antibiotic, right? Because we already know. I mean, this is the 21st century, so we have enough data already that doctors are confident about what broad spectrum antibiotic to use initially. Okay, so I mentioned that there are standard antibiotics, so we have a table for that. But first, let's look at the courses. So if it's a uncomplicated UTI, usually short 3-day or 7-day regimens. Now for complicated UTIs, there will be anywhere from 10 to 14 days or even longer, depending on the organism, or sometimes we have multiple organisms causing the UTI, especially with those institutionalized patients. And those that come in with urosepsis, meaning it's no longer local, they have the infection in the bloodstream, those take even longer. We can treat them for weeks or sometimes months, and with multiple antibiotics as well. So for table 49.1 is only for simple UTIs. Okay, so these are the standard UTIs, not urosepsis. This will not apply for urosepsis. Okay. Now you notice that the title is UTI and pyelonephritis. We'll discuss pyelonephritis next. Now, pyelonephritis is no longer a simple UTI. This means if it's pyelonephritis, this is now infection of the kidney. But most cases of pyelonephritis starts as a UTI. So for instance, Miss Bailey, for instance, she disregarded her symptoms. She had symptoms of UTI, but she said, no, I'll just, drink cranberry juice. I can't afford to go to the doctor. I have no time. I have exams coming up. Okay. So she neglected them. Now comes several days later. Now she's having fever. She's now having malaise. So now the UTI went beyond now. So it was able to swim up. So instead of just in the bladder, now it swam up her ureters, and then infected her kidneys now. So that's what we call pyelonephritis. Now we'll distinguish later between acute and chronic pyelonephritis. So here is your table for your medications. There's really not much to study because there are, if you notice, the table doesn't have side effects, yeah? Okay, so you're lucky because the previous edition had more columns, meaning they included the nursing implementation. So at least here, you just need to know which one is which. Okay, now let me, of all these, let me direct your attention on the last one. Look at phenazopyridine. It is not an antibiotic. All of them, all the others are antibiotics, okay, except the last one. What is the last one? This is, the brand name is Pyridium. So phenazopyridine is not an antibiotic. Are we clear? This is only for symptomatic treatment. So patients, since patients complain of lower abdominal or bladder pain, then this is what you give them. It's only given for 3 days. Okay, do not give it beyond 3 days because it's harmful to the kidneys. So this is only for relief of the burning. And a warning, this does stain the urine. So the urine here will turn orange. Okay, remember rifampin? Okay, so similar, okay? Although this turns it orange, not red orange, because rifampin was reddish orange, okay? Like I said, it will depend on what type of UTI the patient has. So if it's complicated UTI, then the antibiotic course is longer than 7 days. And for urosepsis, even longer. And urosepsis does not respond to PO antibiotics. It'll be IV only. You'll have to be admitted. Okay, let's go now to non-pharmacologic management. So how else do we treat the patient? What are our other treatments other than antibiotics?
Flush the kidneys.
Okay, so let's go here. There's a care plan. So for pain, what do we, before we get to the, there's a discharge now to prevent UTIs. So for pain, what do we use again? Phenazopyridine. What else is mentioned here? Application of heat over the perineum. What else? Do we encourage
Drinking a lot of fluid.
what type of fluid? Coffee,
Water.
soda? Okay. Cranberry juice is included there. And what do we do? Do we encourage coffee, tea, spices, colas? Okay.
Even alcohol.
All right. Then voiding, frequent voiding. Voiding helps eliminate and flush the urinary tract. And then how do we wipe? Okay, correct. Back to front. Right. And then, of course, to prevent complications, they should do what with the antibiotics? Okay, complete the course. Okay, not when they get better.
In no sense.
Well, doesn't say it here though.
Oh, it does.
I mean,
He's advocating.
it's that's an option, but doesn't really say here. Okay, so you can include that if you want to, but this technically no. Okay.
Go get your groove on.
Yeah, of course.
You wash before and after.
Yes, very important is hygiene before and after. Yeah, the after part is probably the problem, you know, because the person's tired, you know, exhausted, and that's when you get in trouble.
So she used to.
And then call, of course, they have to know which symptoms to report if they appear, which could be a sign of a complication like urosepsis or worse. And here's your prevention, chart 49-3. So for hygiene, shower rather than bathe. Why?
You do not want to.
Okay, because you're soaking in it. Okay. Plus, you don't really bathe for just a few minutes, right? You spend hours in the tub. Yeah. Again, so clearly says back to front. Oh, is it front to back? Increase fluid intake, again, avoid these beverages. And then frequently empty the bladder. Do not hold. Easy to say if you're not a nurse, yeah?
Yeah.
Oh, yeah, they're going to UTIs.
They,
They got a lot of UTIs. because
They?
have-
Are you not there?
They,
Okay.
I am going to that bathroom.
well, wait
I'm
till you
calling
start
for
working,
help.
okay?
I'm done.
You can't say, it's not like they intentionally did not go to the bathroom, okay? The nature of the job just,
Patient with love.
yeah, myself included. Yeah, even with number 2, sometimes I can't go. Because, what will happen if you go and then your patient, nobody can tend to your patient, so you hold everything.
Then next time you're the patient. Get a digital removal.
Keeping it real.
All right, any question on UTIs? This is it. And please read the rest. They are, especially this part here, but they're pretty much as a summary. Okay, so pay attention to the tables and the charts. Any question? Remember earlier I said there has to be an indication for you to get a Foley catheter? Okay. And I mentioned a few of these during skills lab when I demonstrated the skill. So here are the indications. So if your reason for inserting it is not here, should that patient get a Foley catheter? No. And if any harm comes to that patient, and because you failed to document any of these, will your hospital get any reimbursement? No. Okay, so it's very important to document. Okay, there has to be a legitimate reason which falls among and one of these. So you have a surgical patient, and not all surgical patients will get this, especially if it's a short procedure. So let's say the procedure is 30 minutes. I mean, do we really need a catheter for that? No. So by post-op drainage, we mean, a long procedure, because can we stop the procedure and then assist the patient to the bathroom or put in a urinal or a bedpan? No. Or if, let's say, the surgical procedure is around the perineum, can we afford that? No, we don't want the patient pissing the surgical site. Yeah. So again, the Miss Zapachilla earlier talked about a critical care patient. So that's the second. And then third is the patient has urinary retention for various reasons. They can't pee, either short-term or long-term. Then we have for wound management, some patients have, let's say, stage 3, stage 4 pressure ulcers or other complicated wounds, and they are incontinent. Then can we afford to get feces and, oh well, not in the feces, but urine in the wound? Okay, no. And of course, we leave urinary obstruction. Other than that, should we have a catheter in our patient? No.
No.
All right. So because we have an indwelling catheter now, and because it's necessary, the patient now is at risk for a CAUTI, correct? So can we prevent it? Yes. So now you have to implement a bundle. So this will appear on your flow sheet. So on Epic, a patient, if you add a LDA, a line drain access device, you add a urinary catheter, it will automatically populate on your flow sheet a section on CAUTI bundle. Okay, and then you're forced to document on that CAUTI bundle, or else you'll get a very nice, or most of the time, not very nice note from your risk management telling you, hey, you missed this documentation. Please complete it as soon as possible. Okay. So sterile technique, strict aseptic technique. That's why we give you a hard time in lab. Okay, you miss something, you contaminate it, you repeat the procedure. Okay, because it's mandated by Joint Commission. Secure the catheter. So we provided you with the, what do we call that securement device again? We have the stat locks now, so you're aware of how they look and how to use them. Frequently assess. What do we assess? Okay, so COCA, right? So color, odor, consistency, amount, okay, and also the paste.
Yeah. Word.
Just a little bit, okay? Don't drink it, just, dip a little, yeah. Okay, a bit.
Some poison.
Perform, now, I know this says daily perineal care, but is it really restricted to daily? No, it should be every after a bowel movement or after urinating, because you do the same, yeah? You wipe from back to front, yeah?
Front to back.
Okay, front to back. Okay, very good. So every after, especially a bowel movement. And then maintain a closed system, meaning do not interrupt. You notice our kits have the catheter already attached to the drainage bag, correct? So that's what we call a closed system. If you interrupt the closed system to irrigate it, for instance, that's not allowed. You should maintain a closed system. You can interrupt it with an order, meaning the surgeon or the doctor asks you, okay, so you need to irrigate that. Okay, that's the only time you will have an open system. But as much as possible, it should never be open, okay, because it's impossible to really keep sterile. Yes.
What if you pull the, like you need a sample and you pull it from that,
Oh, that's fine. We do that all the time.
okay, so it's still.
Yeah, but you have to, what she's asking is, remember that port where there's a balloon inflation port where you attach the syringe?
Yeah.
Okay, so you notice the port next to it, there's a circle,
Mhm.
okay, where it's a lure lock. No, you can attach a syringe to it and then aspirate something. Okay, that's what she's talking about. So there is an option there to grab the urine sample, because you can only get a urine sample from the bag itself within the first hour of insertion. Because after the first hour, that bag is no longer sterile because the urine has been sitting there and growing something. Okay, so you can only get your sample from that port. All right, so what you do is just kink the tubing. Okay, kink it for maybe an hour, and then now you'll see urine, right, stuck in the tubing, and then you can aspirate your sample. And don't forget to unkink it. Again, discontinue as soon as possible. What's our standard?
48.
Okay, 48 hours or 2 calendar days. For suprapubic, does everybody know what he's talking about? Okay, so some people with chronic Foley's, the doctor may suggest to the patient and the family to have a suprapubic catheter instead. This has many advantages because now you don't have anything hanging from the urethra, especially if the patient is male, okay? Because we can have the penis, always in pain because of the catheter. So that's an option. So what they'll do is make an incision, kind of like a peg tube. You know what a peg tube is? So this one's not for feeding, of course. This will be for draining the bladder. So it's like having a feeding tube into your bladder. Okay, so it'll be right over here in your lower abdomen. Okay, over the symphysis pubis. That's why we call it a suprapubic catheter. Doesn't really make it any less. So yes, and they also have at risk for obstruction still the same. It's just like any other patient with a catheter. Okay, doesn't really make it less prone to COTI. Are we understanding? Yeah, it doesn't decrease the risk. Okay, it's just mainly for comfort, right? Because if you have to have one, McNair, would you like to have a suprapubic or a regular out through your penis? Oh, okay, yeah.
So Professor.
Yes.
And the urostomy is, replacing the.
Urostomy is okay. So this question is about you know what a colostomy is, right?
Yeah.
Okay. So for colostomies, urostomies, that means the patient has an interrupted ability to defecate or urinate in the normal mechanisms. Meaning, let's say the patient lost their bladder. There's no more bladder. Where are you going to put the urine? Okay, so that's an example. Let's say you lost your bladder to cancer. So now the doctor has an option to, okay, let's create a new bladder for you. Of course, only the bladder will contract. When they say create a bladder for you, this is a non-continent bladder. Okay, so they'll get a piece of bowel, small intestine, and then create a bladder out of it. So therefore, for this to work, you will have a stoma over your abdomen. But they'll redirect this because, again, you don't have bladder anymore. So they'll have to take out your ureters, put it into that piece of bowel, and then direct that piece of bowel out of your abdominal wall. So it's a stoma, like an ostomy, like any other ostomy. But instead of feces, this will store urine. Okay, answer your question?
Yeah.
Okay, so that's different. Nothing to do with UTIs. That's usually under cancer, because that's when we talk about those things.
Oh.
Okay, that's not in this chapter. Okay, that would be under cancer. So here's the picture of your suprapubic catheter. So it's an option again, but again, it doesn't really decrease the risk of a COTI. Okay, same risk. Any question about catheter care and prevention of a COTI? Okay, so last topic, and then we'll go on a break. Let's go to pyelonephritis.
So the Joint Commission standards for the suprapubic catheter is different.
Same. But you have to understand, suprapubic catheters are chronic. They don't put, there's no such thing as a temporary suprapubic catheter. Okay, page 1610. Okay, so under upper urinary tract infections, we are now dealing with a UTI that swam up to the kidneys. Okay, so now we call it pyelonephritis. There are two forms. We have acute and chronic pyelonephritis. Let's compare the two. So let's start with acute pyelonephritis. As already stated, this is caused by a UTI. There are non-UTI pyelonephritis, which are quite rare, meaning the infection was sustained from inside the bloodstream, meaning you had a blood infection and somehow caused pyelonephritis. But again, that's rare. Most acute pyelonephritis conditions are caused by a UTI, an untreated or undertreated UTI. Manifestations. If you look at it, does it include signs and symptoms of a UTI? Yes, because again, most cases are caused by a UTI. So of course, the manifestations will be including UTI. However, besides the UTI, because now this involves infection of the kidneys, what will be added? Low back pain, flank pain, nausea, vomiting. Now we have systemic symptoms now. Okay, beside otherwise, in UTI, it's mostly local, right? Symptoms are over here around the area. But now, because it involves the kidneys, you have systemic manifestations now. And then, of course, still some local, this time involving the kidneys now. To diagnose it, of course, we need to do a CAT scan or at least an ultrasound of the kidneys, although CAT scan would be a better picture or a better diagnostic test. And of course, we have to draw a blood culture also, because if it reached the kidneys, could it have also entered the bloodstream?
Yeah.
Yes. So now we have to do both. This test, an IVP, stands for IV intravenous pyelogram. So this is the use of a contrast agent in order to visualize the kidney. Do a CAT scan, you need an IV contrast. Now, what's just like any other test that uses an IV contrast, what is your contraindication? Besides allergies? Okay, kidney function. Okay, check BUN creatinine. If there is any evidence of acute or chronic kidney disease, the doctor must be notified. and appropriate measures can be done. Doesn't mean we won't do the test. It can still be done, but with appropriate precaution. Examples are, we'll give the patient lots of fluids, okay, in order to protect the kidneys. And then they'll also be given a drug called acetylcysteine. It's not discussed here because this is under the discussion on those tests will be on, actually it's under either fundamentals or in the assessment chapter of the kidneys. If this is 68, I think it's in either 66 or 67. Medical management, because this is a form of infection, so what will be involved here? Okay, antibiotics will be given here, PO or IV. This will definitely be IV. If the patient, let's say, has mild symptoms, they can receive 1 dose of IV and then sent home on oral, okay? But they will at least receive 1 IV antibiotics in the ER. Again, if they're not really septic, meaning there's no evidence that they have sepsis, they can be given 1 IV dose in the ER, then make sure they complete a 2-week course of antibiotics. Okay, so it says clearly there. But again, if the patient has severe symptoms, that could be longer. One thing, and it's specified here. Okay, right here. Never mind. Okay, so let's compare now acute and chronic pyelonephritis. So first of all, what is chronic pyelonephritis? Thank you for reading, Ms. Johnson. Repeated bouts.
Repeated bouts of acute pyelonephritis may lead to chronic pyelonephritis. When pyelonephritis becomes chronic, the kidneys become scarred, contracted, and non-functioning. Chronic pyelonephritis is a cause of chronic kidney disease that can result in the need for renal replacement therapy, RRT, such as transplantation or dialysis.
Okay. Now, first statement is repeated, right? So repeated or recurrent acute pyelonephritis. Now, there has to be a reason why you're getting, because keep in mind, how did you get pyelonephritis? Because you got a UTI. That means, did you have repeated bouts of UTI? Yes, and then you had also repeated bouts of pyelonephritis. Now, there must be something wrong with your anatomy, correct? Meaning nobody gets, unless you're just really, a dirty person, like absolutely no hygiene, or you're not getting enough care. But so most cases here actually has an anatomical anomaly, meaning you either have a fistula or something like that that's causing you to get frequent UTIs and therefore frequent pyelonephritis, and then now you have chronic pyelonephritis. But look at the manifestations though. Do you see any symptoms of an infection? No. So when you have chronic pyelonephritis, what's the treatment? Is it antibiotics?
No.
No, because it's not infection, right? Look at the manifestations. What are they manifestations of?
It's damaging the structure.
Chronic kidney disease now. All right. So that's now your manifestation. So it's something chronic now, not acute. Acute would always be infection signs and symptoms. Signs and symptoms of a UTI, of an active infection. There's no infection here anymore. Although the repeated bouts of the infection led to it. Okay, so chronic is not an infection anymore. So these are more, meaning evidence of you're going into CKD now. Well, not yet end stage, hopefully not. Okay, so you have chronic kidney disease problems now.
Chronic kidney disease, like it's not in reverse.
Yeah, but you can reserve, you can
prolong life.
correct. You can extend what remaining kidney function you have. We'll give you like sodium bicarbonate, just to deal with the acidosis, and yeah, avoid drugs that will further harm your kidneys. Adequate hydration, proper underlying risk factor management, like diabetes, hypertension, So you can, yeah, you can prolong kidney function as long as possible. Meaning you can delay the onset of ESKD. Yeah.
But, during the phase of, when we're doing the treatment for acute kidney disease, there was a section when you said if you over the diaphoresis phase, if you don't.
Yeah, if you miss the switch,
Right.
meaning you expose the kidney to a second injury, yeah, then that will they can recover, right? Because AKI, you can recover. You can have several bouts of AKI. It doesn't become chronic. Yeah, that's the beauty about AKI. As long as you get proper and prompt treatment. Okay, you can recover from AKI anytime. Because remember, how many causes were there that we talked about that led to AKI? Yeah, there were pre, intra, and yeah. So there were 3 categories, right? Pre-renal, intra-renal, and post-renal. So you can have them repeatedly. But if you get treatment each time, your kidney fully recovers.
So for that case of AKI not being treated properly, this one, these are both.
Well, this one is different. This one has a specific cause. This
Oh.
is from repeated bouts of acute pyelonephritis.
No, I'm just for validation. These are both ways that they that a person can end with CKD, right?
Yeah, one of the, yeah, 2, we've talked about 2 so far, PKD and then this one. Yeah, but there are, countless lists as well. No, hypertension, diabetes, they all lead to CKD. Okay. So management really is based on, well, what is your particular risk factor? How did you get chronic pyelonephritis? So we treat that underlying condition. The rest of the management, when you read, this will be about supportive measures to maintain kidney function, to prevent further injuries to it. And these are some of the conditions that lead to chronic pyelonephritis. I won't read all of them. Meaning, if you have these conditions, these are the options, okay, specific options to maintain kidney function. So let's say it's a stroke, for instance, then this will be the treatment, okay, because it can lead to that condition. Okay, let's go to, that's about it. Any questions? Okay, let's take a
So-
break. Yes, question.
Professor, so the antibiotics that are given IV, would it be like if you were to give like an antibiotic, you wouldn't, right? Because the kidney's already.
They can even give, depending on the organism. So let's say the organism is sensitive to vancomycin, or let's say to amikacin, those aminoglycosides you mentioned, amikacin, gentamicin, they can be, but they'll monitor the peak and troughs of those medications. Every 3rd dose, we draw drug levels, blood levels of that drug, and then we'll adjust the medication. The dose, I mean.
A greater type thing, like why they choose to give.
Yeah, I mean, we have no choice. We have to treat it.
Oh,